Okay, I'm going to get started. I think we all got a lot out of that first section. That was about fixing the financial structure for IUTF. And there are people that can do that, and we had some really fruitful discussion there. But now we're going to look at a slightly different angle. We have to keep closing this gap on what it costs and what we can actually do for the money we've got. So this session is going to look a bit more at closing the gap, but from a different angle. We're going to look at innovative, cost-effective approaches to simplifying and scaling treatment of acute malnutrition. So welcome all to this session, and thank you for all the engaging discussion in the last one. I hope we'll have more. We have a team of panelists here, who I'll introduce shortly. But first of all, I want to thank Eleanor Crook Foundation for supporting this event. It's been great, thank you. And thank you all for attending, and everyone online, because I think it's getting late for a few people. I'm going to start with Mesfin doing opening remarks.
Hello, good afternoon. Can you hear me? Yes, okay. My name is Mesfin Tassama. I'm the Senior Director for Health at IRC, International Rescue Committee. Thank you for the organizers of this event for inviting me to share some few remarks, before we go into the panel that you're going to hear a little bit. And as Anne said, this session is about scaling innovative and cost-effective approaches to simplify and wasting treatment. I think in the first session, we had lively discussion whether prevention or treatment is more important. It's not either or. And we are gonna focus here now, what works for treatment. So, we need to focus and answer the right question. And our question this afternoon is on simplifying the scaling Western treatment. And, we talk about treatment because, we are talking about massive number of children who need treatment. Every year, the level of acute malnutrition, 45 million children, but that's even prevalence. We are not talking about even just incidence here. And in the first panel, you heard about RUTF, which is the most innovative and a product that we have for treating children at home at the community level. And the promise of RUTF is actually to expand coverage, reach as many kids as possible who need this treatment. However, coverage has been very low. And I think many organizations who implement CMAM, what is the coverage of the program. And I can quote, some of the area that we have done a real coverage, house-to-house survey, that in some places it is around 13%, 1-3. And majority of children who need the treatment are not getting the treatment. That's the fact. And yes, we have made some progress. And especially, the last few years, there has been some new injection of resource to scale up treatment. I think we are grateful for that. However, we are not reaching all the children who need this treatment. I think, so the question is, how do you make sure that the existing resource also can reach most children who need the treatment? And there are evidence-based, cost-effective solutions that are available that would scale, the effective solutions that we have in our hand. So, despite CMAM, which is community-based management of acute malnutrition, which is a community-based, a keyword, yet, our treatment is dependent on health system, because, the kind of monitoring and process that we adopted for treatment, even though community health workers can easily diagnose and treat acutely malnourished children. So, as a result, our approach is not sufficient to scale and reach the children who need them. So the question is, do you continue doing what we have been doing, or explore new ways of doing and, reaching the maximum number of children who need treatment? And we're gonna hear today some studies that has been done on evidence-based, solutions for scaling treatment. One is study done by IRC on a combined protocol for acute malnutrition. It's ComPAS that my colleague Letitia will talk about. And we'll also hear from Alima about optimizing treatment for acute malnutrition approach. These are some of the studies that people have done in terms of scaling treatments, then to get us inspiration how to do it. We will also hear from countries who are implementing this simplified approach, from Mali, I believe from Kenya. So, during this session, we aim to distill key learning from these studies, as well as the countries that have implemented these, and take, key lessons and adapt it to our program. So, this is directly linked to the N4G objective, which is achieving one of the key elements, which is making the fight against all forms of malnutrition a universal cause. So I'm really looking forward to the discussion, and I'll come back later on, just take some key takeaway, but for now, I'll hand over back to Anne. Thank you.
Thank you, Ms. Bin. So we have three panelists here. We also have one person online, and we have someone else who's going to do a video. So here I have Dr. Rodrigue, who has already spoken to you, so you know him, but he's the Director of Operations for ALIMA. I have Letitia, who is, Letitia, sorry. Letitia is the Technical Advisor for Nutrition for IRC. She's supporting the West Africa programs, so she can talk about that. We've also got here Dr. Samu Diari, who's representing the Ministry of Health Mali. He was the head of the district nutrition team when IRC were doing their research, and he's now the director of the hospital in Dakar in Mali. We also have online Aminata Nadoy, who's in Senegal. She's going to talk to us streamed. She's the director of nutrition for Ministry of Health Senegal. And we've also got Veronica Quirogo, who is currently on a plane on her way here. So she did very kindly video a short piece for us, so we will show that. She's the Director of Nutrition and Dietetics, representing the Ministry of Public Health for Ministry of Health Kenya. So to get started, Dr. Rodrigue, can I start with you? Could you tell us a little bit about yourself, but I think you did that previously. But also, can you tell us about OptiMA and the simplified protocols that you've been working on, why you did them, and what's been the progress? Please.
Okay. Merci beaucoup pour la parole.
No, thank you very much for this invitation to explain to you the simplified approaches. They were mentioned during the first panel session. Now, I'm a clinician, I'm a practitioner, so I come from the field. And let me tell you that increasingly we're faced with situations where we see more and more prevalence of chronic malnutrition or SAM or malnutrition, generally speaking, has become more prevalent. In the fields where we are, in our settings, well, at least for Lima, these settings are emergency settings due to different problems such as climate change, conflicts, or emergency situations, and all these problems catch up with us, and we are faced with the task of saving human lives. Now, this is the starting point, and of course, it forces us to wonder how we can best treat these children and provide and care for them, and what are the shortcomings. Now, for some 10 years now, we've been pondering on this issue, realizing that there's a need for another type of approach for these children to become more efficient, i.e. scaling up our programs, reaching out to more children, reducing the number of children with SAM, and also increasing the coverage with our programs. And this is where we started using the simplified OptiMA approach. So what does it mean? What is OptiMA? This is a simplified approach, and this is even a combination of simplified approaches, and with a single objective, which is to increase the efficiency of our programs along three axes, along three lines. Firstly, making sure that the families and communities are at the very heart of nutritional monitoring of children, so as to identify these children as early as possible and take them to the health centers because we want to prevent malnutrition, which is a severe disease, and we know that the mortality risk is very high. So if we empower the families so that they can identify malnutrition and take the children to hospital, we know that these children will have more opportunities to be saved. So we have started to support the families, the communities. We've trained them to know how to use MUAC in order to monitor on a permanent basis, on a continuous basis, the nutritional state condition of their children, whether they are sick or whether they are in good health, so as to monitor this. So we train mothers, we educate mothers on MUAC, and we also educate communities on this monitoring tool. Second line, we want to also have these children in our health centers for MUACs under 125, and also identifying swollen feet or hands. And as soon as we reach 125 or we are under 125 for the MUAC, we tell mothers, we tell parents that they have to bring their children to the health centers. We also ask them whether there's any swelling, so that we can do away with this silo mentality whereby you treat children in one according to one pathway and some children according to another, so that we deal with all these children according to in the same setting with our UTF, and also we manage to follow up on these children once they are back in their communities. So this is how we think we can impact the incidence of malnutrition in the community, and also to increase the coverage of children with SAM. And the third line is to reduce gradually our UTF in the course of treatment. When we enter the children in the program, well, gradually, as the child recovers, we reduce the RUTF, the ration, gradually, so as to rationalize the inputs, and so that we can take care of more children. So it means covering 2 to 3 times more children with our UTF, because in our communities, 1 SAM child or 4 MAM children. So with this rationalized treatment with our UTF, we can cover more children. This is what it is all about with OptiMA. And it's very similar to other simplified programs that are rolled out in different countries.
Thank you, Rodrigue. That was very helpful. I'm sure there will be plenty of questions about IUTF reducing dosage, about use of MUAC, about these things that some would consider controversial, some would consider very sensible. Thank you. Very good introduction. I think now we'll just move on to Veronica, who's done us a little recording in Kenya. Is that okay to go straight to Veronica? Okay. Thank you.
Good afternoon, esteemed delegates. I sincerely wished to be in France to take part in this important event. However, due to unavoidable circumstances, I was unable to arrive on time. Since the advent of the simplified approaches, Kenya has made notable progress in piloting and adapting these approaches to manage acute malnutrition, particularly in the hard-to-reach areas and emergency-prone areas. Through partnerships with UNICEF, World Food Programme, International Rescue Committee, and other stakeholders, we have implemented simplified protocols in selected arid and semi-arid counties. These approaches have demonstrated improvements in the treatment coverage, continuity of care, and reduced burden on the health system. They have also enhanced early detection and management of wasting at community level by the community health promoters. Our experience shows that simplified approaches can be both effective and scalable, especially when integrated within the broader health system. Some of the strategies that we are piloting include community-based management of acute malnutrition, known as CMAM, which involves training of community health promoters to use simplified tools like mid-upper arm circumferences, tape, for malnutrition screening and referral to health facilities. We are piloting this in Madera, Turkana, and Marsabit counties. The second one is single product for treatment of malnutrition in children. This simplified protocol is based on the revised WHO recommendation on the use of ready-to-use therapeutic foods for treatment of both moderate and severe acute malnutrition. This is a planned pilot which we want to undertake in Wajir, Samburu, and West Pokot counties. The third approach is the family mid-upper arm circumference tape, and this involves training families to use mark tapes to monitor the nutrition status of their children, enabling early detection and self-referral to health facilities for confirmation of nutrition status and management. We are piloting this approach in Turkana, Isiolo, and Tana River counties. The final one is modified dosage protocol, and this involves adjusting the dosage of therapeutic food based on recovery progress to optimize resource use. We are piloting this approach in West Pokot County and the Dadaab refugee camp. Following a national consultative process and review of the global WHO recommendation, we are in the final stages of revising our national integrated management of acute malnutrition guidelines to integrate these simplified approaches. We have considered adoption of at least 3 approaches, and these include community-based management of acute malnutrition, CMAM, use of family mid-upper arm circumferences tape, and the use of single products and modified dosage of protocol of ready-to-use therapeutic food. The simplified approaches are already being operationalized in pilot sites across counties like Turkana, Madera, Isiolo, West Pokot, Tana River, and Marsabit, and also the Dadaab refugee camp. As we finalize the guideline, we aim to expand implementation to more counties, especially those with the high wasting burdens and limited access to facility-based services, depending on availability of resources. Nutrition actors can support the government of Kenya in adopting the simplified approaches in 4 key ways. 1, provision of technical support through capacity building of county teams, particularly as we finalize the rollout of revised IMAM guidelines. The second one is operational research and learning, so that we can continue documenting and sharing implementation research to build the national evidence base on simplified approaches. The third is on resource mobilization, which include investing in the scale-up of simplified approaches through coordinated funding aligned to the Kenya Nutrition Action Plan 2023-2027. And the final one is system strengthening, that is supporting the integration of simplified protocols into routine health system, including digitization of supply chain and nutrition information system. My key takeaway for this session is that simplified approaches are not just a temporary solution for emergencies. They are critical, effective, and sustainable innovation for strengthening the resilience and equity of our health system. As Kenya, we are committed to institutionalizing these approaches to ensure that every child with acute malnutrition receives timely, accessible, and quality care, no matter where they live. Thank you and have a very productive session. Bye-bye.
Sorry, I can't hear the speaker. Okay.
Pilot setting, it's targeting to the most vulnerable areas. It's that theme that I think we'll see more of. And at this point, I wanted to hand over to Letitia Christians from IRC. And Letitia, can you tell us a little bit about IRC's work in innovative simplified protocols and why you're doing it and where you're going with it?
Merci beaucoup pour l'invitation. Thank you very much for your invitation and good afternoon, ladies and gentlemen. So as we've heard today, the IRC asked the same question. What about the coverage? Coverage, I mean, children, all the children want to take care of, they can't wait for this coverage. And as Dr. Roderick said, the national protocols, which are the standard protocols, deal with with children suffering from severe acute malnutrition with two different products. This system is complex, especially in terms of supply chain, reporting, the continuity of care, especially when there are disruptions in the supplies. And this stops communities from having access to treatment. So the IRC was very innovative with these simplified approach, which is an adaptation of the standard protocol. And since like the other players in malnutrition, we're going to work on the management by the community, by the community agents, and IRC worked on adapting the tools for the community educators with who were suffering from illiteracy, and IRC carried out a randomized control trial, which is a ComPAS protocol, which includes the management of the MAMs and SAMs. They have a program with a single product to simplify dosage and reduce the dose based on the MUAC and emission criteria based on the MUAC. Other research have also assessed the groups at risk, other simplifications like spacing out the visits, the frequency of the visits. And the results of this RCT showed that this combined simplified treatment was not lower than the standard. It was even more efficient, up to 25% of RUTFs less to take care of a child suffering from SAM. And the IRC was wondering what was happening in reality. Is this doable to implement this protocol in real life? So the feasibility, the supply of what is inputted, the communities. I'll stop here for the moment. Thank you.
Thank you, Letitia. And again, you can see more innovation, again, using MUAC, but this whole thing about frequency of visits, very important when you've got a long way to travel and that sort of thing. And the excellent thing is, this 25% reduction in use of RUTF. We're trying to close the gap. This is some evidence, starting to gather evidence that we need. Thank you. Aminata Nadoy, from Government of Senegal, is she online? Aminata, I can't see you yet, But would you like to talk to us about your experience with simplified protocols for treatment of wasting?
Oui, bonjour et désolé de ne pouvoir parmi vous.
Hello, sorry, we cannot be with you.
Donc, nous avons plusieurs processus
So we
protocole
have
simplifié, pas la même chose
several
que les autres, mais
processes,
au
not the
Sénégal,
same
nous
things as the
utilisons
others, but in Senegal, we've been using the MUAC since 2007. We carry out screening with MUAC. We have a very substantial system in our communities. It covers 70% of periodical screening and active screening, and there's passive screening based on the MUAC. And in some zones, the screening goes beyond MUAC, and it is based on the weight and the size. Now, what allows us to do this, we've had a lot of experience with Alima, with the management in the communities, with a monitoring system that is lighter, simplified, so the community members could monitor and support some communities so that they can have the therapeutical product, because sometimes the appointments were not respected. The other element concerns how did we manage to make sure that the communities might own this. We reinforce their capacity in terms of management. So they had other systems for MAM. There are other players who are trained, and now we are strengthening the capacity of the community players in these actions. The other element regarding the decentralization of actions with a greater responsibility, because the territorial areas have a greater responsibility in terms of education, health, etc. And we thought it would be important for them to be responsible for malnutrition. And the community members form associations, and we are testing an approach. We know the number of children in the area, and they screen according to the number of children covered. They are very motivated, and the territorial community is there to serve as an intermediary between us and the associations. And this allows us to make this strategy more sustainable, because that is important. It is true that our UTFs, peanut, etc., they're very interesting for MAMs. But as we said in the first session, there are a lot of problems with stocks. And here we are mobilizing the players in the community regarding the sustainability for the management of children suffering from SAM. Here we are insisting on prevention rather than management. Prevention in the community allows us to reduce the number of children dying with an early screening, but also the sustainability of the actions. Today, Senegal is dealing with this budget. It's the first time in Senegal that in the government's budget, we have a line dedicated to the management of malnutrition. So we've never seen that. This is a good progress. And in the field of health, with the community systems, and with the health systems, we are continuing to work on all this. And now there's a provision to ensure, as our colleague said, communication at the community level and the health systems. The relays are followed by the territorial communities, but technically they are supervised by the health agent. And we have responsibility areas. The authorities know what we're doing, and in case of need, they do intervene. So for the moment, I'll stop here. Thank you.
Thank you, Amina.
Hello?
That was another angle really useful. You talked about community ownership and sustainability from that route. We have always called it community-based management of acute malnutrition, but we don't often get the community side so well focused. So thank you for that. And you also added in that the government now have a budget line. Fantastic. Thank you for that. Really helpful. I'm now going to move on to Dr. Diarra, who is going to tell us about his experience with the simplified protocols from work in Mali.
Thank you very much. Good evening. Dr. Samneu Guerra. I am a family doctor, community physician, and I was lucky because I was in charge of nutrition in the district of Kai, which is in Mali. So it is 52 health districts, and for prevention, treatment of acute malnutrition, we've been coordinating that from 2016 to 2023. The 2017 version of the National Protocol on Acute Malnutrition was reviewed in 2022, and in this last version, the simplified approach was included. So the approach was included based on factual data. So currently, we can say that the approach is such that we've given the authorization to implement it, but under certain conditions. Normally, wherever we need to implement this approach, it has to be a place difficult in terms of access. It has to be very remote. That's one of the criteria. Secondly, the care system should not function, or it should be in a zone of conflict. So these are the criteria that precede the implementation of the protocol. And as for the content, because the protocol, the MOU, well, we do as the others do. We include in the protocol, it is based on the MUAC or on the size-weight ratio. So with the simplified protocol, we use the MUAC to include children in this protocol. But the management, the major problem with the management in our districts, what is it? Well, it is the recurring disruptions of supplies. And as said here, there's the MOM program and the MASAPA program with different MOUs and protocols. And in general, the program that suffers most is the MAM program. This is the program that's suffering most because we don't have supplies. And it requires the involvement of a community that is generally poor. So the simplified protocol is very useful at this level because it is the same engine that will be used and the SAMs and the MAMs without any complications. And much before this was included in the national protocol, frankly, when we had difficulties in our supplies for MAM, together with our partners, we would say that we would put the children on plum peanuts with 1 packet a day. We would do that and we got good results. Without being controversial, some people believe that this is not the case, but our observation as in charge of nutrition of the district, when there was a disruption of MAM, we would use plum peanuts to deal with the MAMs, and children would come out cured from these MAM programs. So all this is an opportunity for the efficiency of the system, because we must not forget the costs, because with the inclusion of children in this protocol, the former protocol, a child of 7 kilos should receive 3 packets of plum peanut per day. If you multiply that by 7, multiply by 30, by 4, that is 1 box of plum peanuts so that the child might be cured. But with 2 packets of plum peanut, per day until the child reaches the MAM stage. This makes the program more efficient and it reduces the cost. So this is my experience. Personally, I didn't have to implement this in the districts. I don't know if it is unfortunate or not. After 2023, I was appointed as a director in a hospital, so I didn't monitor children anymore. But this is what I can tell you about the simplified protocol. Thank you.
Thank you very much. And again, a lot of reference to being able to reduce the amount of IUTF. It's talking about catching those children early. But again, everything Dr. Diarra talked about was about making sure it's in remote areas, making sure it was conflict zones. So special criteria to try out, pilot test these ways of working. But clearly you could see some good results. So very positive. What I want to do now is move on to another question. And I think I'm going to combine the next two questions. I wanted to ask you all about some of the key challenges you faced. Key challenges either in implementing just on a normal basis or key challenges to progress and to scale up. So, Dr. Rodriguez, can I start with you? A little bit about how you've gone with what sort of key challenges you faced and then any barriers to scale up.
OK. Merci beaucoup pour cette question.
Thank you very much for your very interesting question, because there's nothing new, actually. No new protocol, no new approach without challenges. And before talking about the challenges, I'd like to go back to how we implemented this program. And this is how we highlighted these challenges. So as I was saying, it's always good to hear the people from the ministries talk about the observations, what they could experiment in the field, which led to the adoption of these simplified protocols. So as I was saying in my initial introduction, there were two observations. There was an operational observation, and this led to questions. And we came up with assumptions that stipulate that doing things differently will increase the efficiency of the program. So we had to test those assumptions because it was a question of health. We are in medicine, so we have to test these assumptions. And we need to have strong proof, strong evidence that will allow us to defend these approaches so that the entities, the communities, the Ministry of Health and the organizations might take ownership of this. Now, for ALIMA, what did we do? Well, first of all, we had to discuss, work with scientists to see how to size this kind of approach. And secondly, when we found the answer, we had to contact the ministries because they're the ones who are going to implement the programs in the field. So we had to go meet the ministries and explain to them with the evidence, with clear ideas, how we started with the assumptions, how we will implement these activities and these approaches in the field. So once the ministries understood the basis, now it's up to the community because the community must understand what we want to do. They are used to experimenting other programs. They are used to other ways of management. So we had to begin with the community, explain to them what we wanted to do, and make sure that they accepted and adopted this approach. And the communities did follow us. Although we had some difficulties in some areas at the beginning, the communities did join us and supported us to implement this program. That's the case of Niger or DRC. And I'd like to thank the ALIMA and the Nutrition Agency in Congo that agreed to help us to implement this program. So a lot was done together with them. So first, we set up a clinical trial, as said by Laetitia, in DRC. And this controlled trial allowed us to obtain arguments. And thanks to this trial, we saw that the OptiMA approach was not worse than the standard protocol. It was as efficient, especially if we compare the SAMs, the SAM children that are managed with the OptiMA protocol and the standard protocol. And based on that, we saw that OptiMA was more cost effective than the standard protocol. So therefore, our controlled trial is underway right now, and we're waiting for the results. So these are all positive signals, and this led us to collaborate with several countries to test. This is the case of Mali, this is the case of Chad, this is the case of other programs in DRC. It's also the case of other programs we've opened in Niger that allowed us to collect a lot of information that shows us, and we'll still have to discuss this, that shows us that these approaches can be easily implemented. And in terms of difficulty, in order to answer your question, as I was telling you, these are questions that require to redefine, to obtain scientific proof that can help us implement these approaches. So the challenge is to first collaborate with scientific institutions. This is the case with ALIMA and the INSERM, with whom we've worked a lot in the field, internationally and in the various fields. And we have to collaborate with the ministries also. You mentioned the criteria mentioned by several countries, how to implement these protocols. And there are several in Burkina and in Niger, since these are areas with high safety risks. There are a lot of centers that are not functional, they're closed down. And in other countries, we analyze the previous results to see if the community has enough food. Otherwise, we can activate these protocols. So there are a lot of criteria. So we have to collaborate with the different ministries, especially the health ministry, so as to set up these approaches. And the other challenge is to speak the same language. We talked about this in our first panel, and that's the case with the IRC. We collaborated a lot with the UNICEF, with the MSF, and we really had to harmonize things, speak the same language, to have the same advocacy that would help us change things. And the major challenge is at the community level. I'm going to caricature. If you take a mother in Niger who is used to receiving 14 packets for her children until 2020, and now she only receives for the same child or another child 7 packets. Well, she's unhappy, but we explain to her, we tell her, and that's the basis, in the community. It is the basis of our success. So long as we do not work with the community and for the community, we cannot do our work properly. So the community today, especially in the places where we have implemented these approaches, the community can easily explain this simplified approach, because in a community, if there's a child who is malnourished, a child who can receive the treatment versus 4 or 5 children, whether it is a moderate or severe, they receive the treatment from the communities and they help us in these approaches. So these are the challenges that we had to experiment, but these are very promising, and this allows us to work without too many problems.
Thank you, Rodrigue. Again, it's talking about this communication, making sure people understand what's happening. It's introducing something new, something strange, and all that time investing is paying off. That's great. Thank you. Letitia, do you want to tell us a little bit about challenges you have faced? Thank you.
Oui, merci. Sans vouloir répéter.
I don't want to duplicate what Rodrigue just said. We also implemented different pilots studies in Mali and elsewhere to test out the acceptance level in the country, in the North District of Nara in Mali. We supported the implementation of the simplified protocol at district level with the support of the government, of the ministry in Mali, and also with the supplies from UNICEF. So the protocol was implemented in the health centers, and in order to scale up coverage, we tried and reach out to the communities with relying on community health promoters. And we think that ComPAS is really has an added value because it can be dealt with by promoters, health promoters, with a literacy level that is lower. We've also worked on transportation and storage, on sustainability, durability, and accountability as well. Yet another challenge is the fact that we want to scale up coverage. According to ComPAS, you need to manage both mother and child together. We know that the cost per child is lower, but the overall cost is higher. And this scares the ministry, and rightly so. So it's one of the challenges we have to tackle. And so we mentioned the financing needed for RUTF, but I think it is important to guarantee coverage. We need to bear that in mind so as to avoid the extension of or the increase in the number of malnourished children. Now, with the cuts, financial cuts and aid, we know that there's going to be a shortage of supplies in some fields. So we need cost-effective solutions, but making sure that the nutritional needs of children are covered. So we need to strive for optimization and not just reduction. We know that in some cases we need to be very attentive. And with regard to dosage, this was mentioned, so I won't say anything about it. And also, when with regard to the management of these children, we know that the MUAC of 115 is not a good cutoff value. We need to go as high as 125 to make sure that we cover all moderate and severely acute malnourished children.
Thank you. And again, you brought up something that, again, can be very controversial when you're successful at these programs and increase coverage. Some people will say we can't afford that. But the evidence base is increasing that if you catch these children early, you're actually not increasing the cost, but it's more information that's still coming out, and it's really important information because that argument comes up a lot. Dr. Diarra, anything you would like to add about some of the challenges that you saw when you were involved in these programs?
Tout à fait.
Yes, indeed. When it comes to challenges, I can say that for a nutrition specialist or for someone in charge of the health system or health center, the major challenge is a financial one. So you want to make sure that it's cost effective because the consumption of inputs is very high. So the consumption of supplies is very high. So in my view, this is a scientific challenge also with regard to the management of these patients, with regard to cost effectiveness and efficiency. Now, we said so, results are on par with what you obtain with other protocols. However, if you compare the former approach, once the patient was discharged from the SAM program, the patient was then monitored through the moderate acute malnutrition programs. So we need to make sure that with a simplified protocol, we can still monitor these children properly and therefore enhancing cost effectiveness. Now, the national protocol in Mali does allow for a simplified approach. However, there's always a challenge to scale up. And in order to do so, you need to underpin this with evidence. You need also to train people. You need to extend the approach to other districts and involve the community health promoters. These community health promoters or workers are very important for preventing acute malnutrition. They are absolutely essential in the system. So we need to make sure that they can act as efficiently on the basis of a simplified protocol. So financial challenge, scientific challenge, these are the two types of challenges I can identify.
The whole cost to scale up. Everyone's been trained in the other protocols, so scaling up is going to have a cost to it. But in the long term, if it's cost effective, it's worth considering. Yes, and you talked about the community health promoters. Again, absolutely key. So they've got to be involved. They've got to want this. They've got to own it. Thank you. Very helpful. Aminata, is there anything you would like to add on the challenges and progress? I'm assuming we're seamlessly going across technology.
Pour nous, les défis, c'est que
Aminata, did you manage to get that question?
voilà. Oui, j'ai bien entendu. Pour nous, les défis, c'est...
Yes, indeed, I got your question.
Vous savez, quand on est dans la prise en charge, quand il s'agit de cas de malnutrition aiguë sévère, surtout quand c'est compliqué, les familles
When
se
faced
déplacent
with
pour aller
some children,
de santé. Et ça, c'est
families
beaucoup.
tend to take their
Il
children
s'agit de
to the
ménages
health
vulnérables,
centers,
il s'agit de zones enclavées.
and it comes
Les
at a
zones
cost for them.
enclavées,
You see,
quand
when
la
they
famille
come from
accompagne ou la
very
maman
remote
accompagne l'enfant
areas,
qui est malnutri
or
aiguë sévère,
they
et
really
lorsque
have
la
a
phase
very limited income.
d'hospitalisation,
So
les autres enfants qui pourront
when the
laisser à la
mother
maison peuvent
stays
tomber dans
in the
des
hospital with the
tomber dans la
some child,
malnutrition.
while the other children are left at home and run the
Le
risk
défi,
of
c'est
ending
d'approcher tous les services
being
communautaires
malnourished, acutely
pour
malnourished
que
themselves. So this is
les mamans puissent
a big challenge
achever le traitement,
to make sure that mothers
régulièrement respecter
can
les rendez-vous,
ensure
prendre
the
soin des
treatment
autres enfants
while
concernés.
taking in
L'autre élément,
care
c'est
of their
les
other
défis
children.
en termes de protection sociale. Je
The
pense que le
other
volet
point is the
protection
cost
sociale doit être intégré dans
and
toutes nos
social
stratégies.
protection. I think social
Parce que
protection
c'est
should be
un
part
élément
and
très
parcel of
déterminant pour
every
nous, en tout
strategy
cas
we
pour le
roll
cas du
out.
Sénégal.
It's
Le volet
absolutely
protection
essential.
sociale est très
Well, at least in
déterminant
Senegal,
dans la prévention, dans la prise en charge de la malnutrition.
really, it's
L'autre
quite
élément, c'est que
crucial for the
je pense
management
que
and
lors
prevention of
du premier
malnutrition.
panel, j'ai entendu dire il faut de plus en plus qu'on essaie de voir
During the first panel
c'est
session, we
vrai
heard
en termes de
something
si on prend
that
l'aspect commercial, économique, peut-être que c'est pas rentable pour le secteur privé qui produit les aliments
highlighted the lack
pense que
of
pour
profitability for the
approcher
private sector
la
that
production
produces
de
this
en tout
food.
cas au niveau
However,
du pays,
I think
moins ça
that
va coûter.
the closer
Je
you
pense que
are
ça, c'est
with
des
production
défis que nous avons
from
de
the places where
protection en
this
termes
food
de
is needed,
proximité des
well,
services
the
pour
cheaper
la
it
prise en
is.
charge.
So these are
L'autre
the
défi,
sort
c'est
of
un défi
challenges
de
that
redevabilité
we
en fait.
have to meet. And the other
C'est-à-dire,
challenge is
on veut,
accountability.
si je prends notre exemple,
Let
nous voulons
me give you an
responsabiliser les
example.
communautés, nous voulons
We
responsabiliser
want
les collectivités territoriales.
communities
Mais
to
derrière, il faudrait qu'on ait un
be
mécanisme de
accountable,
suivi
likewise for local governments.
fiable,
However,
mais adapté
in
au
order to
contexte
do
qui
so, we
n'est pas
need
un
to
contexte
have some tools in order to
administratif.
monitor
Donc ça, c'est vraiment
what
des défis que nous avons. Bien sûr,
they
je pense
do.
que le défi financier, tout
And
le
of
monde en a
course, in
parlé.
a
Donc c'est
context
ça les
that
quelques
it
défis
is
que je voulais
adapted
partager avec
to the
vous.
country. And of course, the financial challenge is someone that one mentioned.
Thank you, Aminata. What a great panel. Well, everyone's coming up with another angle on this, and Aminata talked about the cost of the family. We're talking about being cost effective. It's got to be cost effective for the recipient of this treatment too. And so really good we're talking about that now and getting it closer to home. Social protection angle and everything needing to be context specific. What we're all talking about these days. So thank you. That was really helpful. In the interest of time, I'm now going to suggest we have a few questions and answers from the floor. If anyone's got any burning questions for the panel.
If anyone has any questions, please do introduce yourself. We'll take one or two from the floor and I'll go to online afterwards. We'll start with Brian over here.
Thank you very much. Very insightful discussion. And yeah, I actually really also believe that optimizing and making everything more simplified and cost effective is really the way to go. I just would like to ask about, well, in the context of in the context business where when we say that you should not put all your eggs in one basket, and I understand that the ComPAS and OptiMA protocols are not only about providing the RUTF to both SAM and MAM, but it also has other aspects to it. But I would like to focus on that aspect of providing one product to two different forms. Given the supply and the supply fluctuation of RUTF that we've noticed even before the current problem with USAID and whatnot, I'm just wondering if the strategy, if we're putting our bet on one product for both SAM and MAM, are we not exposing more children to supply chain disruptions? If there would be a supply chain disruption or RUTF, then more children will not be receiving any treatment. Whereas if you have a more diversified portfolio, you have RUSF and RUTF, then if there's a disruption in one of these products, at least the other group of children will still have something. Also take into consideration that RUSF is easier to implement. In terms of local production, it's closer to local, it's easier to scale up in terms of local production, also because of the higher and stricter requirements for WHO and Codex for the RUTF that is not necessarily there for RUTF. So I would just like to ask the panel, what do you think about that in terms of the supply of RUTF and the disruptions in the supply chain? Thank you.
Thank you for that question. Very good. Would anyone like to answer that question? Go ahead.
This is a very good question. And I'm going to focus on the last part of your question to start with. I say that until very recently, we used to have both types of food, RUTF and RSUF. So this food for supplementation used for MAM. However, when we deal with SAM and with a program that works more or less smoothly, though despite shortages, as we experienced last year, and on the other hand, when you consider the programs that are based on the USF, well, 1 out of 5 last year experienced problems. So the production of just one therapeutic food in one system dealing with acute malnutrition is something that can prove much more beneficial, well, at least in my view, as opposed to production and supply chains that would be different. So I think simplification at all levels is beneficial. Now, let me be very blunt. In the field out there, you sometimes see children in the severe are not taken into account because they are only moderately malnourished, but they will, of course, end up in the SAM. And in 83% of our countries, of our settings, we are in areas where families can't just make ends meet. And so the moderate cases systematically become acute cases. This is why I think we should have just one type of food. And this will make things much easier, both in terms of production, supply, and use.
Thank you very much for your question. Actually, in the field, there are more MAMs than SAMs in general. So the MAMs double the numbers of SAMs. And when you don't have the inputs, if these children are not monitored well enough, they'll become SAMs. Now, if you put all the children on plum peanuts, wouldn't there be a disruption? That's a possibility, but you have to take into account the quantity of plum peanut to distribute to children in the framework of the simplified protocol. With the former protocol, I remember this, the children of 7 kilos, we gave them 3 packets a day. If you multiply that by 7, that is 21 packets, multiplied by 4 for a child. That child with a simplified protocol, it's just 2, according to the protocol in Mali, just 2 packets per day, so 14, therefore. So that is much less than the 4. Yes, there's that. As I agree with you, we need to verify, we need to look at the difference and try not to have any disruptions. Now, we have to extend this program also to everyone. I would like to add, if possible, sure, your question. I do understand it. It's a very good question. I think that today, regarding the codex, the RUTFs and RUSF, there's very little difference in the composition. And although there is a transition, the RUTFs are funded by UNICEF and the RUSF by the World Food Program. So by joining forces, this could avoid disruption issues more globally. And this is the new guideline of the WHO. The proposal between the two to treat the MAMs with high risk with RUTF, and in the other context, all the MAM children. So that is part of the solution. There is an implementation plan from UNICEF and the World Food Program. We still have to look at how things will progress. The definition of the high-risk MAM still needs to be determined, and things have to be simple in terms of implementation, and that's where all the challenges lie.
Another question, but
Great, I'm going to come to Ibrahim. There are a few questions online just asking for a very quick explanation of the key difference between OptiMA and ComPAS. It's come out in your talks previously, but could someone just give a quick refresher on the main differences, please?
Oui, alors je suis pas experte en
So
OptiMA.
I'm not an expert in OptiMA, but the difference is mainly, and you can stop me if I'm wrong, it's especially on the calculation of the dose of the therapeutical product. And ComPAS is based on the EPB. And you give 2 packets per day per child when the child is an SAM up to a weight of 115, and 1 packet per day until full recovery, whereas OptiMA bases the dose on the weight of the child. Am I right? Is that the main difference? Yes, that's correct. It's almost that for OptiMA. The difference is not that huge. These are simplified approaches. In one batch of simplified approaches, there are a lot of simplified approaches, and OptiMA is a combination of several simplified approaches. And ComPAS, as Madam just said, it's a reduction of the dose, which is based on the PB. So you have one packet if you're yellow and 2 packets if you're red. For OptiMA, the reduction of the dose is based on the evolution of the PB. So PB under 115 millimeters, or greater or equal to 115 millimeters for the MUAC, and under 120 and up to 124 millimeters. That's for the MUAC, and that's triangular according to the weight. And according to the evolution of the MUAC and the weight of the child, we attribute the right dose of the RUTF. But as for the identification of the children, the monitoring, the simplification, these programs are almost all similar. It's just a change in the dose. And as for the dose, even in terms of quantity, for the same children in the same interval, when we measure the MUAC, the difference is not that huge. Thank you very much. Thank you for all your explanations. At the beginning, when we had launched these simplified approaches, at the beginning, there wasn't a great consensus among the players in nutrition. And now we see that the positions have changed, which is a very good thing. But with the current context, with the budgetary costs, with the shortage of products, it's very difficult. Now, the countries that have experimented this approach, whether it's in Mali, DRC, or Niger, they're reviewing their national protocols so as to include this in the protocol. And that's what I'd like to clarify. Now, the question is, are there additional studies that are planned so we can assess the risk in this category of children that are managed with the simplified protocol? And now, as for the MAM cases, we are encouraging community approaches with the local products to deal with the MAMs. It's a question of sustainability and efficiency. Now, I do not know how to link this up with the monitoring, with the RUTFs for children suffering from MAMs, members who are in the community on a permanent basis. We recommend using local products, enriched flours, because it is more sustainable, it is more economic, and it's smarter to do it like that. Thank you. Shall I begin? These are very good questions, 3 very interesting questions. I will begin with the last one because this follows what I just said. Nothing replaces prevention. So wherever we implement the standard program or the simplified approaches, we have to talk about prevention. Prevention is health, vaccination. We have to promote local food, local produce. But here in this room, tell me, in all the places where we work, the places where we have nutrition programs, where can we really talk about self-sufficiency, promoting local produce? Where can the families find that food? I think in more than 80% of the cases, especially for us at Alima, the context is not favorable. So we have to help the families in a different way so that we can take care of those children. So I would say yes, so long as we can, we have to stress prevention, promote local produce, local food, and ask the families to help and support their children in terms of nutrition. But the reality is totally different, and you know that. All the operational who are in the field, they all know this. As for your point on additional research, yes, that's absolutely clear. There's a lot of additional research, as you said, on relapse and the non-respondents. It's not all the children. All the children do not respond to these simplified approaches. So we need to carry out additional studies, and this will consolidate proof, and we will find additional strategies to meet all these points that still exist in the simplified approach. And the third question I forgot, I'm sorry. Yeah, the inclusion. The inclusion today, based on criteria that we mentioned already, we talked about safety, we talked about the disruptions, and this is very important for the appropriation of these simplified protocols. There are zones where we have disruptions all the time. There are areas where more than 50% of the sanitary structures are closed. I'm thinking about the north of Burkina Faso. I'm thinking about other regions in Niger, in Mali, in Yono. These are areas where we do not have the choice. We cannot implement these simplified approaches, and the ministries are helping us in this respect. So if we think about the appropriation, the ownership of these approaches, we have very transparent discussions with the ministries of health in the different countries. The countries follow the recommendations of the WHO, also in terms of nutrition, but we have very transparent discussions, and most of them agree with us. There are ongoing mechanisms of analysis and appropriation. That's the case of Burkina Faso, that's the case of Mali, and as the gentleman was saying, they've adopted the protocol. It's an advocacy, it's an ongoing discussion. I think that we're on the right path so that people might appropriate it, might take ownership of this protocol. Now, to talk about Mali more particularly, the simplified protocol is part of our arsenal against malnutrition in Mali. In Mali, it is already part of our protocol. Now, as for the relapses, there were studies carried out on relapses with ComPAS, and I think with OptiMA too. The definition of relapse varies. In ComPAS, it was 4 months. I'll refer to the last ACF study in Niger. It went up to 6 months, and there are rates of relapses that are quite high. But indifferently, whether it's a standard protocol or a simplified protocol with a reduction of the doses, we have to carry out further research, but there's no research proving that the simplified protocol leads to more relapses. But the WHO, in its new guideline, accepts these simplified approaches over a short period of time in specific contexts and in situations of emergency. The WHO, in its review, only accepts the randomized controlled trials. All the studies on the pilots are not part of the review, so we have to continue working on all this. And it costs a lot to carry out a randomized controlled trial. That's the other problem. And I'd just like to add, you remember the COVID period. We used the simplified protocol, of course, in all countries. So we are going to change things considering the context we have today for the ownership of these protocols in countries where we have 90% of safety risk, we will implement these protocols. Just to give you the example of last year, the supply was a real challenge. I was saying this in the first panel. We had continuous disruptions, and it's the authorities who came to meet us to reduce the dose per child. That was the case in Chad and Niger. We didn't have the choice to implement these simplified protocols. So we are inevitably going to go towards this system of having simplified protocols.
I think there's a lot here. I think this whole thing about being context specific, having an arsenal of tools is, I think, what you referred to. We need to keep looking at ways to close this gap. And there is certainly some very good evidence that's coming out now to say that we can do a lot more. Unfortunately, with time, just wanted each of you to very quickly say one key message you wanted to leave behind today. Maybe can we go to Aminata? Aminata, have you got one message you would like to leave the group today? Maybe not.
Bien sûr. Je pense qu'il y a besoin qu'on ait plus de partage d'expérience.
We need to share our experience more often.
C'est vrai, on a essayé PB Maman avec Alima.
Tried things with Alima. We've experimented things.
Je pense qu'il y a besoin qu'on ait plus de cadres de partage d'expérience.
That we need to share our experience between countries. Check the simplified treatments, simplified protocols, because even with the plump peanut, we don't want other people who are not suffering from malnutrition to touch that. And those who were suffering from MAM, we didn't want them to start using plump peanut to avoid confusion on the use of these products. So that's the reason why I would say that it would be good to share our experience. Not that people should meet, but there should be platforms where we could share all the best practices. Mali with 2 packets per day, what is their experience? We like to share all that experience. And we are beginning to do this gradually with the simplified approach to save time, and not make the same mistakes. Thank you.
Sharing, really important. Can I hand over to you, the three of you, quickly, because we're running out of time. Thank you.
Well, I think that because of the reduction in finance, the current situation, we have to maintain continuity of care in the areas at risk with safe and efficient and good quality protocols. So that's my message, and that's the role of the NGOs to work on all this. Thank you. Yeah, I agree with Laetitia. We have to keep working, and our sole objective is to increase the efficiency of our programs, to deal with children suffering from SAM, deal with them early enough so that we can have an impact on mortality due to malnutrition. Today, we cannot consider mortality due to malnutrition as a fatality. We have to go beyond, and that is important. And in order to do so, we have to federate all our actions. We have to speak the same language, and we have to converge towards the same advocacy. Well, I will simply say that we have to live with our times. We have to adapt our actions according to the context. The context today is less funds, less finances, and considering the needs we have to reinvent a lot of things so that we can reach our objectives. That's my message. Thank you.
some very good key messages there in these difficult times. Thank you everyone for your time. I'm where we have a minute left, so I'm actually going to hand over to Mespin for some closing remarks and a call to action.
Yeah. Thank you very much, Anne, for moderating, and also, of course, for the GRACE panel. I think they deserve a round of applause, I believe. So, yeah, we have heard, many versions of simplification. I think, the message is very clear. We need to reach as many kids as possible with the treatment that you need. The key point is, how do you improve coverage? And how can we scale this effective tool that's in our hand to reach the children who need them? We started off our discussion with the size, the scale of the problem. We cannot just simply, innovate or tinker on the margin and be able to, serve these children. We have to transform the system. And the WHO has come out with clear recommendation with a new guideline. But we feel like that I think it hasn't gone far enough to enable simplification and scale. And I think some of the point we heard, how do you ensure community health workers will be able to do the treatment at home, at the community? And can you use just only MOAC for diagnosis, treatment, and dosage? And what about the mother who need to diagnose and refer the children, to the nearest community health worker? So, the key point about simplification, efficiency, cost effectiveness, all are these critical, insights that we gained. But the question is, why are these simplifications are not adopted? I think Veronica from Kenya said that it should not be the exception. We should make it a standard of care. So what is holding us back from achieving that goal, that this is included as part of a treatment, protocol? I think from my perspective, one is the key challenge is we don't have clear national guideline in every country. And we are using multiple versions of simplification. They are all trying to achieve the same objective, but follow different paths. So I think we need to really have clear guideline that is included in national protocol as well as in the national guideline. So that's where I do think that we all have a role to play. As implementing agency, we need to help Ministry of Health to adopt this protocol. As a Minister of Health responsible for the national guidance, they need to create, enabling environment, legislation, all the things that is needed to be able to adapt and utilize this approach so that we don't have to negotiate in every situation. I think that's the reality today. And I think we need to move beyond that. And the other thing is, we also need to be, ensure that N4G, Nutrition for Goals, it's a key moment for commitment. How many countries are making this commitment to accelerate the scale up of treatment? I do think that we need to make our voice heard so that no child is wasted to die. And I think we have a solution in our hands. So let's do it. Thank you very much.